The topic given to me is challenges in choosing prenatal genomic test. What I'm going to do is just uh, give some case scenarios to explain or just to tell you how we handle the issues and challenges facing those cases. So before that, in brief, prenatal genomic diagnosis, that's what is it? What is prenatal diagnosis? One should know about it, when it's done, why it is done, what are the genomic tests, what samples are used, challenges affecting this decision, which will be just described, illustrated in the end of it. My earlier speakers have made my job very easier, and that's why I'm not going to go into the detailed steps of every molecular test or prenatal genomic test that we did. So why is it done? It's a prevention of recurrence in family. All of us know that. And that prevention is in case of the many genetic condition. It could be congenital birth defects, dysmorphism, developmental disabilities. We heard about it, several genetic syndromes. There could be autism. There could be, again, the bad obstetric history, stillbirth, neonatal death, and the sibling death, or consanguinity and advanced maternal age, various endocrinological, neurological muscle disorders, epilepsy, etc. Could be familial or also the non-familial. So you will be having the cases which are coming with mainly, which are very obvious as birth defects, dysmorphism, disability, intellectual disability. We heard also from the earlier speaker, and which we can find out whether they are, you can see over here is the Down syndrome, very classic thing. You can have ambiguous genitalia. You can have the family coming with 3 generations, as you see in the end, or you may have the consanguineous marriages with the affected sibs, and they are coming for prenatal genomic diagnosis. So the first job of ours is to suspect a genetic condition, and we saw it also. It should be with the detailed history and the genetic complete evaluation. You just divide into genetic or non-genetic or high-risk genetic factors. So if there are something like skeletal dysplasia, familial, 2 sibs are there, you have characteristic Down syndrome, you know it is genetic, okay? The autism, it is also neurodevelopmental heterogeneous disorder, CP, mental microcephaly, etc., okay? So what is genomics? When I saw it's Tom Roderick, the geneticist, way back in 86, he introduced this term as genomic. So it is an area within genetics that concerns the sequencing and analysis of an organism genome. So it involves the study of all genes at the DNA, messenger RNA, proteome level, as well as the cellular level and the tissue level. So that's the genomic, okay? It includes proteomics also. So why the genomic test we have to do is, as I said, accurate genetic diagnosis of the index case is the prerequisite. So though it's a prerequisite, very ideally we read what has to be done and with the algorithm. But when the time comes and the patient is in front of you, you have to handle the different issues. Parents carrier testing, therefore, is very, very important before any prenatal genomic diagnosis. And it depends again from the case to case. So various fetal samples, what are they, and the various laboratory genomic tests also you should know, because you have to choose it. And last but not the least is pre and post-stage genetic counseling. So what are these tests or why is it done? You have to explain it properly in their own language. So here is the slide which is showing all different types of technologies which we heard since morning over here. And this genetic knowledge is very important for the precise prenatal diagnosis or the genomic diagnosis. From the fetal cells, of course, because you are going to do prenatal, so fetal cells are important. And we heard about the microarray, which can do now the very high resolution abnormalities and microdeletions and duplications. So that becomes important. We also had heard about the NIPS, which is non-invasive prenatal screening, and which gives precise diagnosis of conformity. It's a screening test. It's not a confirmatory. So never use the term NIPT. Okay, it is NIPS test, screening test. So that the small amount of fetal DNA is there. And this technology has made it very easier for us to detect the common aneuploidies, because there is the incidence, high incidence, 1 in 700 to 800 live birth of Down syndrome. So some of these aneuploidies like chromosome 21, 18, 13, XY can be screened and confirmed it later on. And that's where you can prevent the overall the genetic burden of it. Now there are companies, you will see that they are screening also all the aneuploidies of all 23 or chromosomes, 23. And of course, you will find for it the algorithm always, how to use this algorithm for differential diagnosis, which test to choose based on your genetic complete evaluation, whether it's a metabolic, you have high suspicion, chromosomal, molecular. Based on that, you do the further testing of it and come to the positive and negative. Now, as we heard from the earlier speaker, the Sanger sequencing or an NGS, whatever you call it, clean exome, whole exome has opened the new era, of molecular diagnosis. And one should know it when and how to use that thing. So when you do the prenatal genomic diagnosis, you will be dealing with the different issues like this, or maternal blood, as I told you in NIPS thing, okay? So it could be amniotic fluid, it could be fetoscopy, or it could be chorion villi. The good amount of DNA will be used. So choosing which genomic test is important for the confirmation of genetic diagnosis. So here there will be selection of various genetic tests, depends on highly suspected disorder. So if you suspect as a chromosomal, you should know which test has to be done. Is a karyotype, or you have to further go for microarray, etc. Or if it is a metabolic markers of IM, and then you are confirming by target sequencing, or clean exome, whole exome, etc. So the purpose of various fetal sample will depend on which genetic test needs to be done. So based on that, you will choose, you have to have a good interaction with clinician and the laboratory scientist for the sample for CVS or fetal blood or amniotic fluid, which test, which abnormality you are going to look. Is it a submicroscopic chromosomal abnormalities for which it will be micro test and you will need a DNA. So similarly, the case scenarios, which I'm going to show you just now, is just the way we tackle some of the issues. And though it is very algorithmically given very nicely in the books, at times you have to listen to the couple or the parents or the families. So as I said, when there is a high suspicion of genetic disorder, very nice, very well described. So you will divide the suspected genetic condition, whether it's a single gene, chromosomal, polygenic, or multifactorial. And based on that, you will choose your test, right? Of course, the pedigree charting is very, very important. And you will also find out whether they inherited or not. Now, in this case, it's a very simple thing. We did the prenatal genomic diagnosis by karyotype, NIPS test, and the 21 trisomy was there. But again, for going for the second child, also we saw that there was already a child there. There is no need that you have to do the parental karyotyping here. But your focus should be more on the training and rehabilitation of this Down syndrome child. So this was a very simple case. But then at times, sometimes there are the syndromic one come and they want to have another child, which should be normal. There is a death earlier. But such very characteristic phenotypes, we know it is a Cornelia-de-Lange syndrome, where they have a clinical facial dysformism also suggestive of it. Little autistic feature, birth history about there, karyotype normal. Now, in this case, because of the genetic syndrome and the dysmorphism, which is very characteristic, you can also diagnose there as a spot diagnosis. You can go for a specific NIPBL, NIPBL gene of it, and that was helpful in a further. It is autosomal dominant, so we have to also explain what is the risk, the recurrence of risk to the couple. Then in case of a single gene disorder, you come across the families who have a neurodegenerative disorder child. We explain everything, what is the fate and the prognosis of it. They have a normal baby also. Despite that, they had come again with the pregnancy because they wanted another child. So that is a scenario when you come across. So both parents were carrier for the mutation of the index case we had done. But for the further prenatal diagnosis, whether it's a de novo or it is the inherited, we had to do that. And then we explained, despite that, the lady was pregnant. And then we did it for the target mutation analysis for her pregnancy, which was normal, and they continued the pregnancy. So sometimes we will come across like that, autism spectrum disorder. This was the case where it's a girl, so we thought it's the Rett syndrome, which was negative. Microarray gave as a duplication of cytogenetic band. It was a very rare and novel, So though there are panels coming for the autistic panel or epilepsy panel, it's not always that you will get it, because you have to remember that we are the Indian population with its genetic diversity. So microarray also was useful in the confirmatory diagnosis. And that couple had specially come for the next pregnancy. Then there are certain subtelomeric also chromosomal abnormality in this case, which is very, very correlated, very, very well related as a autism susceptibility gene. And in that case, the genetic counseling, the pre-test counseling, post-test counseling becomes very easy as such. I'm just skipping these slides. Okay, this is a child. This is the family which I had shown it earlier. If you see there, the consanguineous marriage was there. And this is the A beta lipoproteinemia. We found out because of the very accurate clinical diagnosis, the mutation by clean exome thing. Now they cannot afford again on the parents. We didn't have a chance. She was again pregnant. She was crying. She didn't want to have a child. So then the cost-effective approach, because the family was not affording. So we could find out what is the prenatal targeted, the variant is there. But unfortunately, fortunately, whatever it was, heterozygous splicing mutation, and they wanted to continue the pregnancy because that was a male baby. Here is the case. Sometimes you come across for the prenatal genomic diagnosis. This is a case without the index case. They had only the past history of it, and they had shown this, which is the ARC syndrome, arthrogryposis, renal dysfunction, cholestasis. And the clinician was very good, and also the ultrasonographically. So he had convinced and he had said, yes, earlier baby had died like this. The couple came with the option of not doing it in the carrier screening for them because it's a costly matter. So it's going to be a baby, which is important. So that's how it was continued. We had gone into the search for it, which is the gene which is responsible for it. So next time, just looking at this picture and etc., though we had counseled them with the 25% risk, etc., we did in amniotic fluid without carrier testing, without the index case diagnosis, the gene mutation test. Unfortunately, it came out positive and they did not continue the pregnancy. So this is the situation which you will come across, and then they say, okay, next time we will do it. We heard about the VUS, so I'm going to skip this, and one has to find out, as Dr. Puri said, that you have to correlate it with the VUS. There are other history, you have to correlate with the other clinical phenotype findings, see the literature, whether it is there mentioned or not. And in that situation or a scenario, you can consider that VUS also as the important. This was the case, pregnant. She was already pregnant, if you see, but she just came and described that there are many people, many family members. It's a hereditary multiple osteochondroma and multiple exostosis. And her brother that's the one picture which she showed us also, and she had brought it. Now, in this case, again, she had come also the late, but then when we explain it, the mutation in EXT1 and T2 gene, though which is the heparin sulfate functional abnormality, and the bones are not formed properly. And therefore you have this, and it's a very classic familial. But it was first time, that time she said that she doesn't know, and no family members know why this is happening. So it was a first time diagnosis, and we could do further in her pregnancy. Though it was, again, came out as the abnormal one, and then she did not continue the pregnancy. ART is there as a boom, and those who do not get the child within 2 to 3 years or something, they may opt also for it. That's how now the trend is. But this is a baby who was there out of IVF baby, a very good obstetrician clinician, though it was everything nice, but she just suspected as the baby's, the neck, the web neck, like. So just casually, just to rule out, I had given, and otherwise family was very happy, everything. And then we had here 47 triple X syndrome, though it's not going to be the MR as such, but the effect on her, on the couple, though it was a precious child, precious baby, and next time they have to go again for such a thing, where PGD also comes. So do we need a chromosomal testing in all ART couples? We had done also prenatal diagnosis of triple X in women. And last but not the least is, in the era of NIPS, you will come across various challenges. Here is the case, 31 years, they had earlier, and second one was there, a very Marwadi family. opting for a male child, but never disclosed us everything. High risk NIPS test was done. And that time they had the USG was normal and no aneuploidy was observed on NIPS for T21. But when there was a fish was done, there was a mosaic and low grade mosaicism 5% was there. So both results were the contradicting. And we didn't know what to do it. So we had to continue the pregnancy or not. So take the support of the literature, where we found that if you have a very low level true mosaicism for trisomy 13, you can continue if there are no ultrasound abnormalities. And they were the journal proof which we used it for the counseling. So at times you have to take this approach like this when they come for your prenatal genomic diagnosis. So important points to remember. Along with this is the legal, ethical, and social issues. Always the informed consent, confidentiality, stigmatization, discrimination also, and information, your information or diagnosis may concern the other insurance government company. So challenges is in fetal genomic test is sometimes affected individual may not be there or died long ago and there was that time there was no test or diagnosis done. Or maybe the absence of index case diagnosis, the late pregnancy, inadequate infrastructure, cost factor, and the time, what time they are coming to you. So at times phenotype genotype correlation may not be proper or possible rather. And the interaction between clinician and lab scientist is the important, which is at some times is lacking. And that's where the patients also suffer. And at times it is not possible to have a prenatal genomic. And it's always a teamwork. As you know, it's a geneticist, counselor, the lab scientists, various prenatal diagnostic procedures people, expertise. They are also the team of this prenatal genomic diagnostic team. We have like that. And here you will see those where we give several training programs to do the prenatal diagnostic procedures. So it is evolving spectrum of genomic testing. There is a shift towards genetic panel and genomic test, but there are these blurred boundaries between research and clinical services. We need proper policy, governance, and achieving, especially important, is the variant interpretation in NGS reporting. Responsibility for review and managing also the incidental findings. All those factors should be taken into consideration. So the future if in genomic diagnosis is now digital world, which we have the automation, digital tools as telecommunications, smartphones, artificial intelligence has come, and they can also help in identification of the risk patients who are at risk, or these digital technology can assist in further differential genetic diagnosis, improve medical history also. Maybe the risk assessment they can help, and the educational support and the follow-up of the patients. And last but not the least, we always have a challenges in Indian population with our population, annual birth rate with high consanguinity and endogamous marriages and genetic diversity. So thank you so much for giving me this opportunity and I thank the organizer and chair. Thank you.
Thank you so much for this nice presentation on challenges in choosing prenatal genomic testing. Thank you so much, ma'am.